Hi everyone, my name's Victor Khou. I'm a researcher at the University of Sydney, and today I'm going to be talking about the natural history of cardiac and peripheral vascular deaths in kidney failure. So this is an Australian and New Zealand cohort-based study. So to start with a bit of background, kidney failure, or KF, is a chronic medical condition that refers to advanced loss of kidney function. So in other words, the capacity of kidneys to filter waste from blood is greatly decreased. In the long term, these patients often require some kind of kidney replacement therapy, that is, dialysis or kidney transplantation, in order to stay alive. Cardiovascular disease is common in patients with kidney failure. For instance, in 2018, it was the leading cause of death in Australian and New Zealand kidney failure patients. Management of cardiovascular disease in kidney failure is different, and strategies often differ from general populations. Guidelines for treatment strategies are often inconsistent and lack a strong evidence base. For example, we know that kidney transplantation improves survival, but guidelines for cardiac screening, transplantation eligibility, and secondary prevention strategies vary internationally. Further insights into the natural history of cardiovascular disease would help inform care and help with shared decision-making processes, such as communicating risk with patients. They would also help in research planning and health service provision. Our aims were therefore to characterize cardiac and peripheral vascular death across the natural history of kidney failure, that is, over the period of follow-up from treatment up till death. We also wanted to understand how factors such as comorbid cardiovascular disease, treatment modality, and calendar year would impact on mortality rates. So we did this using ANS data, which is a clinical registry that contains information on all kidney failure patients who undergo kidney replacement therapy in Australia or New Zealand. This registry provides information on patient demographics, medical comorbidities, treatment modality, and their cause of kidney failure. So we then linked these patients with their respective national death registers. So Australian patients were linked to the National Death Index using probabilistic linkage, and this was based on full name, sex, date of birth, and date of death. Meanwhile, New Zealand patients were linked to the Mortality Collection database, and this was done using deterministic linkage based on a unique identification number. Each of these registers provides the underlying date and cause of death as ICD-10-AM codes. So the ICD system is an internationally standardized classification of cause of death that allows us to generalize our data with international cohorts. We were then able to calculate mortality rates from cardiac and vascular death stratified by various demographic and clinical factors. We were also interested in looking at how cardiovascular disease status affects outcomes post-transplant, such as rates of graft failure and death. We developed a multi-state model which examined probabilities of patients occupying various transplant and death states over time. So overall, our study included over 60,000 patients, over 380,000 person years. There were 7,551 deaths from cardiac and vascular causes out of 34,000 deaths in total. That is, 22% of all deaths were from cardiac and vascular disease. The median age of our cohort was 59 years at treatment start, and the majority of our patients were male, of European ethnicity, and initiated kidney replacement therapy after 1995. So this graph here shows rates of cardiac and vascular mortality in dialysis patients over time from treatment. The graph on the left shows time across the first year of treatment, whereas the graph on the right shows the first 15 years. So you can see on the left here that within the first year of treatment, rates of cardiac and vascular mortality peak around that second month from treatment initiation, and after that remain fairly steady across that first year. Beyond the first 12 months, rates then gradually increased with time to a maximum at around 6 years from dialysis initiation, before then declining over time. Comparing this to transplant patients, we see quite a different temporal pattern. So in the first 12 months of treatment, transplant rates start out high in that first month post-surgery and then decline quite rapidly to a low level in that first year. Beyond around 3 years of treatment, mortality rates from cardiac and vascular disease then increase gradually over time. So these graphs again show patterns of cardiac and vascular death in dialysis patients, but now stratified across calendar year. So on the right, we can see that mortality generally increases with time, as it decreases from the pre-1995 patients in the dark green to 1996 to 2005 in the yellow, and then from 2006 onwards in the light teal. On the left, there's a bit more of a mixed pattern. So there's a lot of crossing between those three lines, indicating that there's little improvement over calendar year in those first few months of treatment. So this suggests that despite overall improvements in outcomes over time, we should be taking a closer look at preventative strategies to reduce deaths in those first few months of dialysis. The results in transplant patients are encouraging, with mortality improving with calendar year across all stages of follow-up. We can see in particular, beyond the first 3 months of treatment, that cardiac and vascular mortality rates are close to zero in patients who start treatment after 2006. However, it's worth noting that there is still this relatively high risk period of cardiac and vascular death immediately following surgery. So this here is a graph showing graft failure rates in post-transplant patients. So the yellow line here shows patients with comorbid cardiovascular disease compared to the dotted green line in patients without those medical comorbidities. Rates of graft failure are similar across the two groups, both in females and males. However, when we combined graft failure and death as a single composite outcome, we found that rates of composite graft failure and death are higher in those with those medical comorbidities compared to those without. And this graph here shows multi-state probabilities of death and transplants over time from treatment. So what we did was we divided our patients into 6 groups based on death status and transplant status. So our groups are alive following transplant, alive without having ever received a transplant, non-cardiovascular death without and with transplant, and in cardiovascular death with and without transplant. So all patients started out as alive and then moved between groups when they either died or when they received a transplant. So we were interested in seeing how the percentages in each of these groups changed over time. Cardiac and vascular death is shown here in orange, and this occurred in 2% of patients at 1 year from treatment, approximately 9.5% at 5 years, and 15% at 15 years. Cardiac and vascular mortality post-transplant, shown here in the dark orange, was less common, occurring in only around 2% of patients by 15 years. The proportion of living transplant recipients, shown in the dark green, increased across the first 8 years of treatment, and at 15 years, over 80% of living patients had received a transplant. By this time, a majority of patients had died from non-cardiac and vascular causes, as shown here in the yellow. So to conclude, despite improvements over time, cardiovascular death is still a common cause of death in kidney failure. This is especially true in the first few months of treatment, which represent a high risk period for cardiac and vascular death, both in dialysis and transplant recipients. More research is required to help improve cardiovascular disease prevention strategies and preemptive kidney transplantation, which may improve outcomes especially in new patients with kidney failure. Multi-state probabilities are a useful tool that can be used to inform clinicians and patients about the likelihood of cardiovascular outcomes, and can therefore improve shared decision-making processes and guide future research and service planning. And I'd like to thank the following organisations for their support. Thanks a lot.